Hello, everyone. Happy New Year and welcome to the Connecticut Psychological Association Social Justice Speaker Series.
Want me to go upstairs?
I'm delighted that our esteemed speaker tonight is Dr. George Davis. Dr. Davis's talk title is Dialectical Behavioral Therapy, All Things for All People. A warm welcome, Dr. Davis.
Thank you.
My name is Shiva, and I serve as the chair of the CPA Social Justice Committee. Joining me today are our passionate social justice members, Beth, Kyler, Andrew, and Anne. As always, I express sincere appreciation to our sponsors. Their support is the cornerstone of our ability to maintain this series. So I'm going to share with you the supporters' slides. As you see here, we had in 2024 the following people who donated us, and we were able to maintain the series. For 2025, I'm very honored to say that the Comprehensive Neuropsychological Services donated us for the 5th consecutive year. Also, the CPA Educational Foundation has been supporting us for the 3rd consecutive year. Also, you see the name of Dr. Robert Bourgeois, who donated us in 2025. So I also would like to say thank you to all donors all throughout the years. And over here, you see your beautiful names here. So with all appreciations that I have for our donors, I'm going to turn it over to Andrew to share with you additional information.
Just a second. My thing disappeared. I'm so sorry. There it goes. Okay, I'm sorry. On behalf of the Planning Committee, we are thrilled that you could join us this evening, and we sincerely hope that you will continue to attend our future speaker series sessions. We are enthusiastic about Dr. Davis' presentation this evening. As a brief reminder, the CPA Social Justice Speaker Series offers free monthly meetings to CPA members, the wider Connecticut community, and our nationwide supporters. I welcome you to our speaker series this evening. I'll now hand it over to Beth to present the biography of our speaker.
Okay, thank you very much, Andrew. It's a pleasure to have Dr. Davis here. Dr. George Davis is Clinical Director at Center for Dialectical and Cognitive Behavioral Therapies in New Haven, Connecticut, and Clinical Instructor at Yale Medical School. He has extensive training in cognitive behavioral therapies, as well as in psychodynamic treatment. He has been conducting DBT therapy with individuals and in groups since 1995 and was a trainer with Marsha Linehan's national organization. He has worked with the full spectrum of psychological disorders in adults and adolescents in multiple settings, including hospitals, a child and adolescent residential treatment facility, and in multiple outpatient settings, including college counseling centers. He served as clinical director at Linwood and Living Free substance abuse treatment programs for adolescents and adults. He has provided program development consultation to multiple state agencies and schools and has conducted DBT workshops nationally. He developed the DBT outpatient program at Yale New Haven Hospital. It is now my true honor to invite Dr. Davis to lead us through what promises to be an insightful and inspiring presentation. Dr. Davis, the platform is yours.
Thank you, Beth. We've considered the possibility of trying to say that questions could be asked if you have them along the way. I'm glad to see it looks like there are a lot of people out there, a number of whom I know from blast from the past. But we'll see whether it becomes useful or intrusive. I'm planning, if there aren't a lot of questions along the way, on allowing at least 15 minutes at the end for questions that haven't come up along the way, if that works for people. That said, the next slide. It begins at the top talking about adherent DBT, and that's kind of related to what my DBT, All Things for All People was intended to address. Many people seem to say that they do DBT, but I know many people are not in DBT. Some of them actually are people that I have a workshop that I have done. Alas, that does not mean that so I just wanted to give an overview of what real adherent DBT is, so that people will know whether they're doing it or not. And that's not necessarily a bad thing, but it's just the question is whether you're doing DBT informed treatment or DBT adherent treatment. Because DBT adherent treatment have 5 primary functions. And if all 5 of those are not included, you're not doing adherent DBT. One of the functions that is intended to be addressed by adherent DBT is the ability to act effectively. And that's addressed through DBT skills. DBT skills are typically, I guess, always really taught in a DBT skills training group. You say the reasons. One is that Marsha Linehan, who originally tried to do everything within individual therapy, discovered that she couldn't teach the skills and address what were the crises of the week that were going on with clients. And she was originally developing DBT specifically for those with what she was borderline personality disorder. Originally, her interest was those who had self-injurious and suicidal behaviors that were really very disruptive, but it's people who were diagnosed as having borderline personality disorder. But one of the things she discovered was that many, for reasons I will at least allude to, frequent skills that people who have been taught in an average expectable back and forth between childhood and adolescence, a reasonable expectable environment, are skills that people just learn about and not do. When you're really upset, when do you need to calm down, and when do you need to express what you're upset about? How do you do that in an effective way in order to get your needs met? But she discovered that a lot of these people simply did not have the skills for doing those things. So there are skills that need to be taught in a systematic way. But she discovered in the group there are at least 2 advantages. One is dual session. There was more of an opportunity to address the needs of. Today we're just talking about distress tolerance skills. So we're not going to talk about your boyfriend leaving and you're attempting suicide on Monday, because we're just going to follow through with the handouts that we have, which obviously does not work. So that was one of the reasons. The other is it's useful for people to hear that they're not alone in having questions about, gee, how do you do that? You know, how do you let someone know that you would like for them to doing what they're doing in a way that doesn't so you actually get your wishes observed? So that there are a number of reasons that it makes it more desirable to do in a group. Occasionally, nowadays, there are people, if there's more than one person in a group, that one person might do an individual skills training and someone else is the individual therapist. And in even more rare situations, an individual therapist may have one meeting a week to just do skills training and a different meeting in the week to address to really therapy issues, if you will. May need to come back to any questions about that. It's hard to do. I can tell you from personal experience that most of the patients or clients that I'm seeing do have a very hard time, as well as I have a very hard time in sticking to that differentiation in a very careful way. The 5 functions that it needs to address is really improving motivation to change. And that happens through having a connection that really is the cornerstone of dialectical behavior therapy. And so a lot of the things, and some of them I intend to address a little bit later, at least in an overview, are the issues that come up for an individual therapist trying to do a dialectical behavior therapy or dialectical behavior informed treatment. The third is to inform and to ensure changes that they are going to get out of the individual session and generalize outside of that session. I think a lot of people who've been around for a long time anyway have discovered that you can have wonderful things that happen in an individual session, and then you're astonished that the patient doesn't know how to do those things once they get out in the real world. Whether it's getting really emotionally overwhelmed or whether it's simply applying how you're going to do these things that you did about during your self-exposure for obsessive compulsive disorder, for example, that may be very easy to do in the office, but very difficult to do out in the real world. So the way Marcia set up to do that would be to say that if you're going to be doing an adherent DBT, you need to be available to provide coaching for skill outside of therapy or outside of scheduled sessions. Now, some people panic when they hear that and think, my God, if I have these borderline people 24 hours a day, they're going to be calling me in the middle of the night and I won't be able to have a life of my own. I can tell you it really doesn't work that way. Of course, part of it is the therapist who agrees to do this needs to make it very clear, and sometimes even by putting a handout saying, this is what is my definition of coaching outside of a session is. It doesn't mean you can call up and complain to me, just was said to you walking down the street, because that's something we can address in our regular session. But if you're trying to use a particular skill and you realize, oh my God, that doesn't seem to apply now, or am I doing it wrong? Or is this just an impossible situation? And occasionally, in less than 5 minutes, I can tell you my personal rule has always been that coaching calls are limited to 5 minutes. My colleagues are more generous than that. They usually have a 15-minute rule, but because if I can't address it in 5 minutes effectively, it's probably not coaching around a skill, but it's something like looking for an emergency meeting, which is not what the intent is of coaching outside of a session. Another critically important function in adherent DBT rotation group is to provide support therapy for the therapists as trying to help them stay adherent to a DBT model. So those are very important areas that went on. And the 5th section originally was just to provide an environment that's going to be supportive of both the patient and the therapist. Now, this was put in originally because DBT was just conducted in either a research setting or in a hospital setting. So the part there was to be sure that you would have nursing staff and auxiliary staff around the way that would know what you were doing in terms of your work with a particular client. Since that time, people have added this structuring the treatment environment to include things like discussing medications with a psychiatrist and being sure that the psychiatrist is on board and knows what you're trying to do. And as the old saying goes, using skills, not pills, to try to address any particular distress that comes up. Let's go to the next slide. Now, of course, within this, what makes it a informed strategy is to provide some balance of acceptance and change, which is the biggest dialectic of all. Am I going to say something? I'm not really going to say much more at this point about dialectics, so let me just slip into dialectics here. And that means giving a little bit of a history about where DBT came from. In the beginning, Marsha Linehan was a radical behavioral therapist. That she was trained at Stony Brook, and went out to Seattle, University of Washington, and as being a radical behaviorist. It's like, and the radical part of a radical behaviorist is saying that a behavior includes things like thoughts and feelings, and that all thoughts and feelings can also be analyzed in terms of either operants, just reinforcers, or punishers, or classical conditioning, and that all of those things can be understood within that particular paradigm. So since Marsha, and some of you may come back to this later, but from her personal point of view, her real interest was in dealing suicide and parasuicide. If she began trying to use these nifty behaviorally oriented treatments with people who were suicidal or engaged in severe self-destructive behaviors, she didn't get to do her research because they all walked out and didn't come back again. So she thought, if I'm going to be able to get a grant that is actually going to have patients that are going to stick with it, I'm going to need to be able to add something different. So then she began realizing, oh, wait a minute, although she was just focusing on change, that wasn't going to work unless she could be able to adapt and to help clients accept that sometimes we're at a point where we need to just settle down and deal with what is right now, because right now, what the problem is, we're trying to change things too quickly. Maybe a patient who's trying to change their significant other, and their significant other isn't ready to change, and they want to keep the relationship, but they're screaming at them all the time that they have to change in all these ways, and their significant other just leaves in the same way Marsha discovered that her patients did. If she tried to just get them to change. So there needs to be some balance occasionally. Now, originally, as she began getting into this, she tells the story slightly differently in her big book. But I know personally what really happened was that she was beginning to get involved because there was a whole group of psychologists at University of Wisconsin in the 90s, late 80s into the 90s, that were all really into Zen practice. And they participated in Zen mindfulness training groups and Zen meditation. And so from their point of view, they kept bringing in this notion about, no, what is, and this moment is the only way it could be, but the next moment might be different. And so they were bringing in this idea, and she's saying, oh, that's what I need to do in my therapy, is how to settle down and focus, even though those are contradictory. So she played around with ideas about doing paradoxical therapy, which there's a literature on, and she does include some of those techniques in DBT. But in this back and forth, she toyed with the idea briefly of calling it Zen behavior therapy. But at that point, she still did not have tenure. And she figured that she was never going to get tenure if she said her. So while she was complaining about that, one of her graduate students said, oh, well, my boyfriend is in the philosophy department talking about Hegel and Marx, and you're talking about a great idea. We'll call it dialectical behavior therapy. So she got tenure, actually. So the story has a happy ending from that point of view. The unhappy part is in trying to explain to patients what dialectical means. And the really short form of that is that opposites exist in the same moment, and that trying to recognize, understand that there's validity in each of those points of view. That we need to search for what's left.
Dr. Davis, you're muted. We cannot hear you. You are muted.
Can you unmute him, Shiva?
Yes, actually, I'm going to do that.
Now,
He's back to being muted.
Andrew, can you unmute Dr. Davis? It seems that.
All I can do is ask him to unmute.
So, Dr. Davis, is it possible for you to unmute yourself?
host, am I?
Yes,
Am I?
there you go.
Did that work?
Yes.
Okay. I don't know how long I was muted.
It was
I
just
muted as I was talking? How far was I along in talking about Marcia and dialectics?
it was just 1 minute, so you can continue.
Okay. All right. Now we're going to go back. Okay, so had I gotten as far as Marcia getting? Did I see someone say yes or no? That's a yes from Shiva. Okay. But so then I explained that part of it is really trying to search for what is left out, opposite sides. I'm looking at Shiva because she usually says yes or no. Yes, I had. Okay.
Yes.
But in doing that, one of the things that she emphasized that it's important to go back and forth, that you don't get stuck with just one side or the other in terms of addressing what's effective or ineffective. That in fact, if someone really is being rated to become an adherent individual therapist, each session has to have at least 3 round trips between acceptance and change. So that you need to find a way of really totally what the patient is talking about and moving to it, and then moving back to a full acceptance strategy, and then being able to move to back and forth. There have to be 3 round trips. All right. And that's part of what's meant by speed, movement, and flow. It's I mentioned at some point that she really thinks of DBT as really being more of a dance than anything else, because it involves the therapist and the patient needing to go back and forth and looking at and being able to read one another in terms of whether one is feeling invalidated or bored with the other, whether it's the patient or the therapist, and trying to get back on track and make an adjustment. Can we see the next slide? And so a critical aspect of this is the whole notion of validation, and really looking like you're interested and you're totally with the patient, instead of that you're off thinking about what am I going to fix for dinner, or what happened today, or gee, is this patient really going to pay their bills for the month, or do I need to bring it up now or later? But instead, level 1 validation is simply being fully present, and carrying it. The highest level of validation, the 6th, is called radical genuineness. And that is that you're treating a patient in the same way that you would, that you're a real person relating to another real person. And as Charlie Swenson, a psychiatrist who is a real major guru in DBT land, says that really he thinks that level 1 and level 6 are the 2 essentials for doing effective therapy. And I don't think that's just in DBT therapy. I think that's in any therapy. Now, I look back to my psychoanalytic supervisors who would be horrified at my saying that they're 2 real genuine person, because you're the analyst and they're the patient, and they're the sick ones and you're the healthy one. But that's not the assumption in DBT land. The DBT land is that the people are just people. But even within that general framework, a second level of validation, what helps some is simply accurate reflection. Someone says something, and this is the good old things that people think all psychologists just do, and is saying, when someone screams, I'm storming out of here, and you say, gee, it sounds like you're angry with me. That might be an accurate reflection, but sometimes it in itself can feel invalidating when you think that you're doing a level. The other is sometimes, and this is the level 3, is what I think a good psychoanalytically informed there, and that is trying to articulate what has not been verbalized, either in an emotion or a thought or a behavior pattern. And to say, well, no, you're claiming about being really angry with me, and we know a lot about your history with your mother. I'm wondering if that's what's really feeding your anger in this particular session. Now, and if you're right, that can be something that feels quite validating. Oh, of course, now that makes sense. But if you're wrong, it can feel very invalidating. The other, level 4, is validation in terms of past experience or biological dysfunction. And the mistake we make then is it's like, well, of course you feel like, killing yourself. You have a major depressive disorder. Maybe we need to increase your SSRIs. Because you have a biological dysfunction, and that's where we can understand. Sometimes that is a higher level of validation, and sometimes it's like, you're just not hearing me. You don't appreciate that I'm depressed because life sucks, and everybody hates me, and I can't find any worms to eat. So it doesn't do any good for you to say, oh, I understand that someone, given your past experience, would do this, instead of a level 6, which is anybody would experience that, given the situation that. And the other, a level 5, is a little bit higher than that. And it's like, someone who has been through this particular background that you have had would be really upset, which may be a normative functioning kind of thing. But it's not anybody could. It's anybody who had been through your unique experience would feel that way, which can be pretty good. I mean, it's something that it comes up in PhD experiences very much. Of course, someone attacked you when you were going down that alleyway by the movie theater. You're telling you're not going to go to that movie theater anymore. Oh, of course, now I remember. That makes sense. You had that horrible experience. Of course, we're not going to go there. We're not going to go that way. I can understand that. So that would be a validation in terms of the context that is normative functioning. Okay. And radical genuineness I've already touched. So let's go into the next one. And that I've kind of alluded to a number of what these things are already, that it's just sort of that behavior can be valid. And remember, behavior includes, in Marsha Linehan's land, emotions and cognitions as well. But behaviors can be valid in terms of a lot of things. Back experience, an individual, one aspect of it, but not another. There are some people whose feelings are very important, but the reality is not there. It's like, I understand that you could feel that way, but that's not what a fact is. You could understand that you did not win the election, but the fact is you did not win the election. I understand you feel that way. And there's validity without the fact being valid. And there's sometimes when it goes the other way around, when facts line up in a very certain way, but it isn't congruent with what an individual's feelings are. So that there are a lot of back and forth with invalidation, and it's not as straightforward as you would think. And these are things that a consultation group can be very useful in having someone, as you describe, oh, this is what I was doing with this patient. I don't understand why they got up and ran out. And sometimes the consultation group can say, well, let's just replay what was going on. And then they can help you see, oh, yeah, I thought I was validating them. But in fact, I can understand now that it was really very invalidating for me to take that particular approach. And that's a difficult one for a lot of people to understand. I mean, I think we all kind of try to do the best we can as therapists. I think it's always a good idea to stop and think, let me replay what's just been going on. I thought I was being very with them, attending to what they were saying. I thought I was validating, looking for clarifications, but clearly I missed the boat. So that's something that I think is useful for everybody. Go to the next slide.
George, just real quickly, Richard Briggs in the chat is asking the question. He would like to know, should the therapist take on the role of being a validator?
I absolutely. Absolutely. The reason I say that, the question is because, see, that's inherent in accepting. If you're able to accept where someone is in a particular moment, you're going to need to convey that to the person that you're with. And that is an essential, if you're unable to convey that in some way, it's unlikely that your patients or clients are going to continue back. I think that was an early part of what Marcia learned when she couldn't even load up one of her early research grants because people just wouldn't complete the study that she was planning on being adequately validating. And as I described before, it's like there's validation and there's validation. Having said that, you know, in the back of my mind is some of the psychoanalytic supervisors, for example, one who said, I remember very clearly his dictum, this is Roy Schaefer, his position as he would say, well, George, if you don't have something worth saying, don't say something. You know, so, and trying to say, but if you're going to be effectively indicating that you're staring at them is going to be very invalidating. And in fact, that was the reason I quit my my effort to have psychoanalysis with Roy Schaefer, was because he was not validating of what my experience was, and so I left. But I think that if there's something goes astray in therapy, it's always worth reviewing. What could that be? Now, you need to be validating. You don't validate the invalid. If someone comes in and says, you know, as a therapist, I would not say, oh, you're absolutely right, you know, so long. except in the most extraordinary of circumstances. I will. This is a joke, by the way, everybody, please remember this is a joke. One of them was when Marcia had a patient. I know of the patient because she was in hospitals on both coasts. And I know a lot about her, extremely difficult. And she was always going to kill herself and do very, very extreme things and got a huge amount, everybody about it. And one time, about the fourth time around with Marcia, when she said, this is my last meeting with you because I'm going to kill myself because you're an incompetent therapist. People over advertise you. I'm going to kill myself. Out, and Marcia said, "Oh, before you leave, does that mean that I have this session this time open next week?" And in this case, it was an irreverent communication that the patient came storming back and said, "Of course not, you idiot. What's the matter with you?" And so then she was able to sit down and they were able to work out alternatives to her storming out and going out and making yet another suicide gesture. So they were able then to come up with a plan. But in a weird kind of way, there was a kind of backhanded validation going in. Oh, you're really feeling like killing yourself. But I'm going to have an open hour next week. Because that would have been just outrageous, depending on the client. I mean, you'd really have to know what you were doing if you did that. So the question is, does the therapist always validate? No. But there is always something the therapist may have. Oh, I can understand why you feel that the only answer is for you to go out and kill yourself. But I'm having a hard time with it because what I know about you and your life, it isn't all stacking up. We need to find a way that we're going to buy some time here. And even if it's something like just saying that one of the agreements if someone really gets into DBT is you have to agree that you're not going to kill yourself for 6 months because we can't do DBT in less than 6 months. And I don't work with dead people. So if you're going to sign up to do this, you have to agree. We can talk about your feeling in yourself, but you cannot do it. And if a patient can't agree with that, then they're considered in pre-contemplation DBT, and you work really hard to get them to the point where they can agree to it. Okay. Now, within saying that with the slide, saying dialectical dilemmas for therapists, it's like back and forth between oriented to change and being oriented to acceptance. And they're both true. And part of it is any given time, therapists are caught in these kind of dilemmas. Obvious, the sort of non-moving centeredness. I would say that that's what my analytic supervisor was doing, is that he was sticking to a classical analytic stance as he understood it, which is this is what it is. We're here to talk about you, not about me. I don't have something to say and have an interpretation that is going to bring things together. So it may be weeks before I have anything at all to say. That would be non-mover centered, compassionate flexibility. And know that sometimes we slide more into one side or the other. And we need to try to figure out how there is truth to both of those. Compassionate flexibility is sometimes just being a wuss. And that is the sort of trying to validate everything that a client says without saying, no, wait a minute, that doesn't make sense. You've tried that 22 times. What makes you think it's going to be different this time? That we need to move toward, we've got to pull out some skills here and figure out what could be a change. So then moving over toward that. And the other is being able to be benevolently demanding then. It's like, no, I expect you to be here on time for your sessions. You're going to be charged a full amount for a session, whether you show. At the same time, there may be times when you say, oh, you had a flat tire. I can understand. Yeah, I can give you an extra 10 minutes, but I'm afraid I can't do any more than that because of my own schedule. So that, and sometimes you're going to need to be more nurturant, but other times you're going to need to be more benevolently demanding. And that really is an important thing to be aware of. Okay, and I hope people will have some question about that. But again, it goes back then to that basic dialectical principle about understanding that there is colleagues who seems always to be rigid. They may lean toward that direction, or someone who seems to be a complete wuss, that their patients don't ever get any better, but they love that therapist, okay? And it may be because it's someone who's all into compassionate flexibility and being nurturant, but they really don't get the client to make any progress and to be able to make any improvements in their life. So that those are critical aspects of what goes into that. Next slide may be hard for people to see. It's not too bad, but it sort of provides a little bit of a summary about how it applies to other things. In the original assumption about specifically oriented toward people with borderline personality disorder who are constantly getting hospitalized because of suicide attempts or other self-injury behaviors, and that then someone begins at what would be called stage 1 DBT at the very bottom, and then what is described as the DBT house of treatment, it's in hell, which is in the basement of the house, that everything just seems absolutely impossible. And that's a stage where the problem is severe behavioral dyscontrol. And the goal of that level of the disorder is simply finding some behavioral control so that someone is not constantly in a situation where they're in the ER or they're getting hospitalized. And I do have to slip in here the little bit of behaviorism that's also there. Is a little bit of a warning is that it's not intended to be a hospital-based treatment. So it's only under the most extreme of circumstances. And I hope I haven't gone mute. Have I gone mute, Shiva? No, I haven't gone mute.
We are hearing you. You're good.
Okay. But it really is an outpatient treatment. So the idea is to tell someone, and it's a reason, call me up. We need to do what we can do. We can solve the problem enforcing for therapists. If you have a difficult client who's been calling you up and testing your ability and seems unappreciative, and they call you bad names in your therapy session, and it's really annoying, it's very tempting to say, oh, I think you need to go to the ER this time, because you know that they will probably hospitalize them and you'll get at least a few weeks respite. But the idea, again, it's for having a consultation group, is that the group can hopefully help you pull back and they can provide you the support you need. However, when a patient has gotten to that point of behavioral control, the stage 2 is really what are many acts. That when you've gotten those things under control, most people still have axis 1 disorders that need to be addressed. And so it's sort of considered a level of quiet desperation. The goal then is to have non-anguished emotional experiencing. And most of the cognitive behavioral therapies for AD, for OCD, for many of the specific axis 1 disorders that people may have would fall into this stage 2. So you're not going to start in with needing full DBT. And if someone comes in and they don't need full DBT, don't give them full DBT. If they have an axis 1 disorder that has an empirically supported treatment, you do that empirically supported treatment for that particular disorder, unless it's 2 disorder that's causing particular difficulty. 3 is problems in living. These are ordinary happiness and unhappiness is the goal. These are people for whom, let's call it treatment as usual, is what's most appropriate. What I call rent-a-friend, although my consultation group tells me that that's pejorative. But I sometimes do it myself, as long as I can make it clear to the patient that that's what they're getting. They're getting rent-a-friend, that they're really not getting me to use all of the terms of either empirically validated treatments or probably bring in a true DBT treatment. And the last level of treatment, which I'm still aiming for personally, is a level of joy and happiness and spiritual fulfillment all the time, which is the fourth stage of treatment. And that would be a sense of freedom and that everything truly is okay all the time, which supposedly is what a Zen master has achieved. I have, alas, ways to go to reach that level myself. So that said, I am getting a quarter of that time has come. So do people have questions?
Dr. Davis, thank you so much for your talk. And also, I apologize that there were some disconnections at some times with the internet. So is there any question that you might have about BPT? I personally, when you were talking, I experienced myself with my patient. It was quite on spot, and the way you experience and you shared with us, like dancing with them, it really makes sense, and being on the opposite sides at the same time and creating that balance.
Right.
So let's see if there are questions. And feel free to unmute yourself if you have questions.
If it would help, I can start off. I was curious, are there any ethical implications of limited DBT availability?
That's a good question. Let me tell you the good news and the bad news about that. Well, try for two good newses. One is that, for example, in Connecticut, the only place that I really am aware of right now that really offers DBT with all 5 of the sections is in the outpatient Yale New Haven program, which still does have a DBT program, and they take Medicare and Medicaid. So that is one of the ways that people can get it, but it still limits it for a lot of people. That it's an ongoing thing in terms of fights with insurance companies about whether they're going to reimburse people in private practice for doing things like outpatient, coaching and attending a consultation group. And there are some, I can't give you their names right now, who have agreed that they will pay for a package of DBT. But it involves a lot of fighting to be able to get someone in an outpatient setting where they will provide, they'll pay for it. And that in a way is an ethical issue, but it's one that's hard to address. Now, Marcia was concerned about it before, and she set up something that's called the Marie Foundation. I honestly don't know how much money they have now, but I know she's had a lot of fundraisers and so on over time for the Marie Foundation, which provides scholarships for people in need of DBT who cannot find it in their areas. Now, those are mostly in geographically remote areas in the Midwest and the far West that I'm aware of who actually benefited from the Marie Foundation scholarships. But it is an issue, I suppose, with any psychological treatment, that we're limited. I can tell you, I reach a point where I expect some kind of reimbursement for my time, over time with clients, particularly when they're very difficult and demanding. So
Thank you.
that's of course, there are ethical issues. There are ethical issues in treatment not being free for all people at whatever they need. That's a nationwide concern, not limited to DBT, in my opinion. Any other questions?
Dr. Davis, is DBT still growing, or has it reached a plateau?
Real DBT is certainly growing. And I say that partly because one of the things is, well, what is DBT for? And there are empirically validated treatments for all kinds of things other than borderline personality disorder. That there are research for depression, for adolescence, which in its own right, but that there are aspects of DBT that can be effective for adolescents, for substance abuse, all kinds of substance abuse, specifically for alcohol. And one of the earlier ones was major studies for opiate addiction that DBT was incredibly successful for. There are variations that go on. It's like for one of the more recent ones that I'm aware of, and it's DBT-PE for prolonged exposure, but it's really sort of an add-on to DBT. It's like the assumption is that someone, if they meet criteria for DBT, they need to not self-injure for, and this is debated whether it's 3 months or 6 months. In her original research plan, they had to be no self-injury for 6 months before they began her prolonged exposure protocol for DBT, which means my needing to slip in that DBT is a program that has protocols for the research that has been done. But it is really based on an approach, a sort of a philosophical approach, rather than hard protocols. And that's something that Marcia was very big on. It's like in one of the first meetings I went to for people who are doing workshops for her, one of the trainers meetings, that was long before there was the second edition of the Dialectical Behavior Therapy training manuals, when everyone was sort of tossing out ideas, and she was, oh, we're going to include this in the next one, and then we're going to include that one in the next. Oh, she said, this is going to be a rule. She pointed to one of her sidekicks, Heidi Hurd, and said, Heidi, write that down. We're going to put that in as a rule in the next thing. And I didn't write anything down. And Marcia said, you didn't write that down, Heidi. And Heidi said, this is not a rule-driven treatment. She said, oh, you're absolutely right. You're absolutely right. It's a spirit. It's a general kind of approach that we need to have rather than it being driven. But it has protocols. So that, for example, if you're doing a substance abuse protocol, there are specific variations on skills training that are included in that. That there's a different thing, there's a different manual if you're doing it for adolescents. There's variations depending on what it is. And this is that Tom Lynch is a trainer who has a whole new thing called it's DBT for over-controlled rather than under-controlled. And that is built on DBT, but it's a whole different approach to people who are really more up, people who are just more closed down. And so the question is this still continuing to expand? It's like, yeah, whenever somebody wants to come up and they're able to go through getting a grant. I mean, Marcia is really retired now, but the behavioral technology program, which is sort of it's like give the papal imprimatur for DBT programs. They're very insistent on having empirical support for it. So in order to do that, you need to draw up exactly what the protocols are within the umbrella of being able to be dialectical in your approach to how you're providing treatment. That was a very long answer to a short question, wasn't it? But that was one of the things I wanted to slip in.
Thank you so much, Dr. Davis. We enjoyed your talk. There was some interruptions with the internet. I do apologize. It seems that, there have been, some difficulties that our participants experienced tonight. The executive director will send you a message about it. And also, I want to acknowledge that in our tonight's talk, we had the president of the CPA, Dr. Fenwick. We appreciate your presence in tonight's talk. And Dr. Davis, we really enjoyed your talk. And we hope we can have you some other days and have the full internet connection and listen to your words, because it really makes sense. And I really experienced myself in the sessions with the patients. So Abeth, would you like to close?
Certainly, Shiva. I want to say thank you to everyone for joining us this evening. Our next social justice event will take place on February 20th, featuring Dr. James Scott as our esteemed speaker. I want to end by emphasizing that our ability to maintain the Social Justice Speaker Series relies on fundraising, and we greatly appreciate all donations moving forward. The donation link and mailing address are available in the chat if you want to support. For those registered for continuing education, I invite you to complete the CE evaluation link to receive your certificate, which is now being added to the chat. Once again, thank you for joining us this evening.
Thank you so
Thank
much,
you all.
everyone. And I'm just adding the information to the chat if you need.
And Dr. Davis, your presentation was wonderful. Thank you.
Thank you.
Thank you so much again. Bye, everyone.